I would leave that exam room thinking to myself, if that were one of my daughters and they were writhing on the floor saying, I'm in too much pain, I can't go to school, could I do it? Could I say, no, we're going, we plan this, we're going? And that kind of humility was really important. That sealed the deal in understanding parents' reactions, where they're coming from, and how much they just love their children and want the best for them.
Welcome to Parent Footprint with Dr. Dan. I'm Dr. Dan. This show is about making the world a more loving, accepting, and compassionate place, one parent, one person, and one child at a time. The key to raising healthy and engaged kids is for parents to seek the same in their own lives while striving to be the best versions of themselves each day. No matter who you are or where you came from, with increased awareness, you can be purposeful about leaving a healthy footprint for your children, your family, and all those you care about while living your own life to the fullest. Today's show is My Legs Are Crying, Understanding and Treating Emotionally Based Illness with Dr. Maggie Kozel. Dr. Maggie, a graduate of Georgetown University Medical School, is a pediatrician and author. She spent most of her professional life in primary care pediatrics and has taken great pride in translating a pediatrician's perspectives into the written word. Her first book, The Color of Atmosphere, was awarded an independent publisher's silver medal for writing in healthcare. She's been an activist for healthcare equity and common sense gun safety, and her numerous commentaries have appeared in outlets such as the New York Times and Huffington Post. In 2015, Maggie accepted a position as medical director of the inpatient med psych unit at Hasbro Children's Hospital in Providence, Rhode Island. In doing this work, she realized she'd been treating emotionally based illnesses in her previous practice with one hand tied behind her back. In this time of pediatric mental health crisis, Maggie's passion for writing from a pediatrician's viewpoint shifted to what patient stories teach us about the emotional brain and the basic skill set that pediatric providers, educators, and parents need to effectively manage pediatric anxiety and specifically school-related anxiety. This perspective and work is in her new book, which we'll be talking about today, My Legs Are Crying, What a Pediatrician Learned About Emotionally Based Illness. Maggie lives with her husband in Jamestown, Rhode Island, and has two grown daughters and spends as much time as possible on her bike. Maggie, welcome to the show.
Thank you. It's a pleasure to be here.
So I was completely touched and moved by your humility and your openness. And at this stage of your career, you've been at this a long time to talk about and experience such a fundamental shift in the way you work and managing it in a way that respects traditional medicine and pediatrics while trying to teach all of us and your colleagues about a very nuanced and sophisticated way of treating complex pediatric issues.
Thank you for that. I took this position as medical director of the med psych unit late in my career, thinking I had seen just about everything, and I had sort of assumed that my role there would be to just kind of handle all the pediatric stuff and try help the behavioral folks realize, or figure out what's real symptoms, what aren't here. And I thought, I went in with great confidence that, this is what I've been doing all my life. And boy, all of that turned completely on its head because I had so much to learn. And I think that's one of the most wonderful things about all healthcare providers, whether it's behavioral health, whether it's pediatrics, whatever, is we need to be lifelong learners, and we need to have that humility
Mm-hmm.
to understand that sometimes things we were sure of turn out not to be true. It's just the reality of
Mm-hmm.
progress. And so this put me to the test. This
Yeah.
experience put me to the test. And what specifically really kind of took me back, was a little hard to process, was that the neuroscience that informs the approaches to emotionally based illness have been burgeoning for the last decade or two. And we know so much more now about the pathways of the emotional brain and how powerful it is in producing symptoms in us. And one of the first things I had to wrap my head around was that the result of the emotional brain, or the impact that the emotional brain was having on these kids, was producing the experience of real symptoms. So if somebody was saying if a teenager was saying, they hadn't been able to go to school for 2 years because their headaches were so bad, it would have been tempting in my previous practice to look upon that with kindness and compassion, but thinking, kind of a diplomacy, like, yeah, I can see you're really unhappy and you're not able to find a way to make this better, but it was kind of a diplomacy. And what I wasn't saying to that teenager was, I know you're in pain. I
Mm-hmm.
understand you are really experiencing this terrible pain, and we know what to do to help.
Mm-hmm.
So that, I think, was the most earth-shaking experience I had on the med psych unit. And of course, the med psych kids that we saw there were at the far end of the spectrum. They were very
Mm-hmm.
seriously ill with these symptoms. But it made me realize, and this is where that humility comes in, it
Mm-hmm.
made me realize that back in my primary care pediatrics practice, I really did not appreciate, nor did my colleagues,
Mm-hmm.
it was kind of just the general approach to school related anxiety. We didn't really fully appreciate how real these kids'
Mm-hmm.
symptoms are, and that realization alone is a game changer. It changes
Yeah.
everything. The way you
Yeah.
align with the patient, the way you align with the parents, the way you can make sense out of treatment for them.
Mm-hmm. So here you are, decades into your career in a position of authority, director, and yet you are going through a specialized residency program with new mentors of all multidisciplines. I mean, it's just so
Yeah.
wonderful. And we'll talk about the nuance, just how words, these simple words, and but, all these simple words mean so much. And your training, medical training, is it in your mind or is it in your body? And you would
Right.
think even with psychology, in my training as a psychologist, it's also similar, right? Do you have a somatization disorder, or do you have like a real disorder, right? It's like,
Right.
is
Right.
this just in your head, or is it real? And that's unfortunate that is the underlying message or communication. And what you found is pain, regardless of where it comes from. And we need to treat that pain seriously, validate it for parents, for everyone involved. And there are some do's and there are some don'ts. And one of the don'ts, which I'd like you to talk about, is the debating diagnosis and the multiple tests upon tests upon tests to rule in or rule out something which is right in your face, like it's a headache, right? Of course we need to know it's not a brain tumor, but outside of that, how far do we need to go to keep peeling back? At times it seems to disprove the organicity of the illness.
Right. Yeah, that's a really good point. And I think that would always be, or typically be, the most challenging part of an outpatient visit, is discussing with the parents how much of a workup you want to do. Because and what I write about in the book is just ordering every test you can possibly think of before you consider an emotional illness is for amateurs. Anybody can do that. But it really takes a more nuanced understanding and a stiff spine as you're talking to this very worried family, to say, I'm hearing the pattern of this illness. I've done my exam. I've done my history. I really think that where we need to focus right now is on emotionally based symptoms. That was oftentimes not received very well, not because the parents were being, trying to be difficult, but because it's sort of counterintuitive, that your response to he's so sick he can't go to school is to say, well, actually, what we need to do is to get him back in school. So that's a lot for parents to swallow. But again, if you're starting from a place, because the parents are saying, I know my son, he's not a liar. He's not faking. He's really, really in pain. And now I know that they were absolutely right. They were absolutely right. Where I was thinking, oh, of course, they love him and they're worried. And so of course that's what they're thinking. But I was not right, in that sense. So pediatricians got part of the treatment right. Pediatricians have been very good about aligning with parents and getting kids back in school, and that restoring function there is a huge part of overcoming school-related anxiety. But we were slow, or still continuing to understand, I should say, that that the child really is experiencing these symptoms, that we have to acknowledge that and stay away from diagnoses, as you say, like debating diagnoses, because that just gets everybody on the wrong track. What I found on the med psych unit, which also had a profound effect on me, was you don't need to discuss diagnoses. Once you can help the child, support the child to connect more directly with their feelings, and once you can restore function, in this case, getting back into school, the diagnoses just fall away by being irrelevant. So all that initial effort to convince parents, no, this isn't whatever, gluten insensitivity or an appendicitis that nobody's been able to find or whatever, that's all wasted time and is distressing to the parents. It doesn't accomplish anything.
Right.
So not debating diagnoses was the second most important principle, I think, that I took away. There's no need to debate diagnoses. We need to just help the kid.
And some examples that you write about in the different stories in the book. So for our listeners to understand, to give more of this emotional-based illness phenomenon some color and some life, is these are people who have all the symptoms of epilepsy without having epilepsy. These are people who have paralysis and can't walk, even though there's nothing physically wrong with their legs or their spine. The list goes on. And so with those examples, tell us, as simply put, like, what is an emotionally based illness?
Great. Thank you for that question. I should have gotten to that a little earlier in the discussion. So what we're talking about is, and again, there's strong neuroscience behind all of this, that the emotional brain is capable of sending out decoy signals or misleading signals that the body is having, the body is experiencing pain, or it could be almost anything. The decoy symptom. It can be difficulty swallowing. It can be convulsions that aren't really epilepsy. The list goes on, as you said. So, what that means is that essentially the physical symptoms that the child or teen is experiencing, and this does apply to adults too, but I'll try to stick to what I know. what that means is that the symptoms, the physical symptoms, become sort of a deflection of the real issues. So, in the case of a 6-year-old who's terrified to be going to school, and we don't know why, and right at the moment it doesn't matter, the function that is being served by the emotional brain is that it's protecting this child from overwhelming anxiety. And we know that children in general are vulnerable, and they crave safety, and they don't really even have the vocabulary a lot of times to express that they're anxious about things. So pediatricians certainly are not the least bit surprised that children and even teenagers will experience their feelings through their bodies. And that seems to be what's happening in the case of school-related anxiety. And the function that the emotional brain is serving is to provide the child, if you will, with symptoms that will sort of, and I'm using air quotes here, legitimately exempt him from school. So the symptoms always serve a purpose. And in children, the most common thing the pediatricians see is that it gives them a reason, it gives them cover for not having to go to school. But again, it's all unconscious. It's not manipulation. It's not faking or lying.
Right.
The child does not want to be sick. And so it's a very tricky situation. It's kind of a nuanced idea at times, but it really is important for pediatric providers of all types and for educators to understand that this is what's happening and that it is real to the child.
Yeah, and as you said, and it's unconscious. So I imagine there's this wall somewhere in the child, let's say their brain, where there is this information that this is serving a purpose and this is keeping you from functioning in places or areas that you feel very scared or anxious about. But the child doesn't know that that's the reason. Like, it's there, but it's out of reach. Like, and so part of the treatment is to open this door to make a connection.
Yes.
To make, as we say back in the day with Freud and psychodynamic work, is to make the unconscious conscious, right?
Yes.
And when you can make the unconscious conscious, now you have something to work with. And this is where all of this magic really in the language, and gosh, I love how you talk about in the book how just the team and the self corrections, the other corrections, the words mean so much, because if ever in this process you inadvertently delegitimize or question the child or the parents about the legitimacy of this, it just sends everything back, because they have to be able to step into functioning and growth in a way where this thing behind the door doesn't pull them back in, right? Because I've always found that, kids, and again, this kids, teenagers, this applies to adults too, but often kids and teenagers, they need to be right. So if you point out where they were wrong about any number of symptoms, it pulls them back into the symptomatology to be right, because they need to save face at like an identity and just part of this integral part of their self. And so, the language and the sensitivity that you wrote about in talking to the patient and talking to the parents is an art in and of itself.
Well, thank you. I had a lot of good role models. And in those first few months, really, I would sit in family meetings with the psychologist and the psychiatrist and the rehab therapist and all of them, everybody around in the room with the parents and the kids. And I feel like my mouth was like probably gaping half the time as I'm listening to them talk, and I'm thinking, why did they say, why did they use that language? Or that sounds kind of a self-conscious way to say something. And I saw it work. I mean, there's nothing succeeds like success, and I learned that the language that we choose is so powerful, even if it's subtle. The unconscious brain hears it, even if the conscious brain isn't hearing it.
Yeah.
So.
And then let's talk about parents in this situation. Parents in this situation, and especially by the time they get to a med ward, right? Like we're talking inpatient treatment.
Yes.
These
Yeah.
are parents who have been through it with their child and teen. They've generally been to multiple specialists, multiple tests, and by this time, no one either has answers or people are saying in so many words, it's in your head and you just kind of got to move forward. And so often, historically, parents are put into and especially if you look at family systems works as well, like parents are put into the role of, well, you're contributing to this. And then some of the behavior that comes out makes it actually look like they are contributing to this. But you also found a place of compassion and understanding for parents who are in this situation.
Yeah, it is a terrible situation for any parent. No, one thing that comes across in these situations is that the parents, almost universally in my experience, want the best for their child. They know their child the best. They know their child isn't a liar or a faker, and they want the best for their children. So when it seems like they're to announce to a third party, when it seems like they're doing the opposite of what you would do if you wanted the best for your child, we have to remember that this is really a family illness, and that's why the parents have to be involved not only in participating in the treatment but helping direct the treatment, learning to distinguish what is their child, who is their child in this, and who is the disease in this. And I think that was our biggest role, was saying, tell us more about what little Joey was like before this all started to happen to him. And that's who we would focus on as Joey, and everything else was the disease, the illness. And parents could wrap their hands around that, and they I think believed us because we genuinely said it. We believed that they really did want the best for their children, but that this is just such a tough illness that can really pull you in. And eventually, again, nothing succeeds like success. They would see their children sort of respond to the kind of therapies that were involved and the emphasis on restoring function. The program had a remarkable success rate. And again, I just kept thinking over and over again, I wish I had known this when I was in primary care practice, because pediatricians have a pretty good success rate with that minor or less severe, I should say, not minor, less severe manifestation of emotionally based illness. We were able to get most kiddos back in school, but there were always those really tough situations where the illness was really entrenched. The parents were just terrified that there was some awful illness that their child had that nobody could figure out.
Right.
And there were times when parents would just get fed up with me, leave the practice, say terrible things, but just because they would look at me and they'd be so frustrated,
Right.
like, what are
Right.
you trying to tell me?
Right.
It doesn't make sense. And I know now that with just a few little things in my med psych skill set, I could have been
Mm-hmm. Mm-hmm.
effective to some of those other children that I wasn't able to help.
We're talking about anxiety and school-related anxiety, of course, the job of kids. So that's like the primary task. What percent would you say, like thinking back on your practice and now with all of your experience in the med psych ward, what percent of the emotionally based illnesses have anxiety behind them versus other issues? Is it the majority?
Oh, that's a great question. Yes, because I would look to my behavioral health colleagues to
Right.
help me
Right.
with that one, and I would say anxiety was overwhelming. We did see and treat some kids for depression. It was hard to know uh, if the depression was. Uh, Part of the problem initially, or if it developed because they'd been laying in bed for 2 years. But
Mm-hmm.
so depression, we did see depression, but anxiety was absolutely seemed to be the number one trigger. And we especially, I would say, we saw a disproportionate amount of patients with sexuality or gender concerns,
Mm-hmm.
because, of course, in the climate that we're in, those kiddos can feel
Yeah.
very rejected,
Mm-hmm.
and have all kinds of struggles in school and everywhere. And so those kind of concerns would sometimes emerge. But it all seemed to come down to sort of a common response of anxiety that was too much, or seemed to them too much to tolerate.
Mm-hmm.
And so physical symptoms, it manifested as physical symptoms instead.
Yeah. So the treatment goal, and this is for from less severe to severe, whether we're in a traditional pediatric outpatient or in a mental health or behavioral health professional's office. The goal is to restore functioning.
Hmm.
That's this. It's simple in statement. The treatment and the process is what takes the sophistication of working with the dynamics of the child, the dynamics of the family, the expected resistance, as we call it, the resistance
Hmm.
to change, the resistance to see it any differently. And the other thing you had to learn was they have to want it. You can't make them want it.
Yes, yes.
And that I know in my work as a psychologist, it takes years to learn those boundaries because you care so much and you are cheering and wanting these people to get healthy and to thrive. But you have to know where to draw the line of what's yours and what's theirs.
Yes, yes. And I don't think that's something that pediatricians experience naturally. We want to relieve distress. I think if you look at the personality of pediatricians, I think that's something we might all have in common. And this kind of work involves pushing kids into distress, saying, okay, so now what we're going to do is have you go to school, and we might do it gradually, take
Mhm.
steps, but we need you to get back in school. And the children typically get
Right.
incredibly distressed by that, and then the parents Most parents get distressed when their kids are distressed, and
Right.
it's really hard. So all of a sudden, we're finding ourselves pushing people into distress rather than
Right.
relieving it. And again, that's not usually where pediatricians live.
And the last place most of us want our kids to be is in a inpatient hospital, medical, any sort of treatment setting. And
Yeah.
yet, again, this is an opportunity for everyone listening, and yet that sometimes is the place where the only place at a point in time that the healing can occur. So, for example, with your former patient, the one who looked epileptic,
Mm-hmm.
this is part of the treatment plan is not responding to any of the seizures. Now, everyone, this is a person without a physiological basis for a seizure disorder having absolutely real seizures, like not fake seizures, real seizures. And part of this treatment plan is letting them be, knowing, of course, you've already assessed for physical safety and lack of physical harm. That part of this process is the psychological aspects of those seizures, the unconscious seizures, not getting an unconscious and conscious reward from the environment. And over
Mm-hmm.
time, that's just a piece of it, but powerful piece. And how hard from everyone who's a caring person, from parent to medical professional to behavioral health professional, to do nothing purposely as part of a
Mm-hmm.
treatment goal.
Yeah. Yeah. That's you actually you described that whole dynamic beautifully. And it is hard, but what we see and actually just an aside, I think that those non-epileptic convulsions that fall into this category um, were some of the quickest uh, disorders I saw turn around,
Wow.
quicker than almost any of the other symptoms, because as soon as you can start ignoring a symptom and not reacting to a symptom, that symptom loses its power.
Mm-hmm.
Those signals have got nowhere to go because nobody's listening, and so that is in fact the treatment. And it does seem a little strange. It certainly seems strange to parents, but it works. It absolutely
Mm-hmm.
works because it takes the oxygen out of the emotional misleading signals.
Mm-hmm. And similarly with a person in a wheelchair who can't walk,
Mm-hmm.
psychologically can't walk, and then the legs follow. They don't work. And
Right,
then
right,
setting up situations where they're not being taken care of, pushed around in a wheelchair. They have to get to the different events, treatments, groups, food on their own. Once you
right,
guys have assessed, of course, there is not the physical basis. And
right.
again, how without reinforcing those very natural reinforcers that anyone loving family members and community members and teachers would reinforce without knowing, you take that away, and all of a sudden, subtly, someone's getting up, someone's
Yeah.
getting food. And again, can you speak to the nuance of pointing out and sort of rewarding and cheering someone's success with at the same time with not giving too much attention to it so the success and function continues?
Oh, sure. And I think we certainly would encourage the patients when they were making obvious progress. But I guess there again, it was that sort of nuanced languages that psychologists know well, where it would. It's more a matter of encouraging them to feel good about themselves that they're
Mhm.
doing this.
Yes.
I hope you are feeling. So we wouldn't say we're proud of you. We would say we know how hard this was, and for you to do, and I hope you're really proud of that.
Mhm.
Um,
Yes.
so
That's an important
yes,
subtlety. Very important
mhm,
subtlety, right? For
yeah,
parents, all of us parents listening, this is also good practice when you're not dealing with an emotionally based when we think about growth mindset and we want our kids to invest in themselves and do things for themselves, not to just get praise and just because we're proud of them. And that's not to say we don't tell our kids we're proud of them for certain things. And hopefully we're proud of them more for their values and their actions than their accolades.
Right.
But this is really not but. And, right? This is a but and you'll all read that in the book. Buts actually stop it, people. When we say but, we stop it. And it's so important for us to reflect this back to the child, to the teen, about them themselves for this intrinsic motivation and this internalization of this milestone, this success, this victory, and this increased functioning.
Yes. That's beautifully said. Beautifully said. Yeah.
So you also write about distress tolerance. This is really important, again, not only for these situations, but for any parent, adult thinking about their children. Distress tolerance is a really important concept. So tell us a little bit about how you see that.
Yeah. So again, I think I alluded a little earlier to the fact that I think pediatricians do not see themselves as people who cause distress.
Right.
It's the exact opposite of what we want to do. So when we have these conversations, I'm thinking about now. I'm going back to reflecting back on my outpatient experience. When we have these conversations with parents about the child will really have to come up with a plan to gradually get little Susie back in school. Then that little Susie will start crying immediately, sitting there on the exam table, and the parents will be like, "Look at her, Dr. Kozel. How can we bring her to school like this?" And often. One of the biggest issues is, and why the parents and child are even in the office that day, is because they need a school note, and because a school note will give them an excused absence. If they get a note from the doctor saying, yes, they were in the office and I saw for abdominal pain, then they'll get an excused absence and everything will be hunky-dory,
Right.
So, and it just more of that reinforcement. And that's a way that schools and parents and even pediatricians or pediatric providers, just out of a desire to be kind, that's how we become accommodators to the illness, because it shouldn't be all wonderful and good that the child is staying home. When the pediatrician is standing there saying, what I'm going to do is I'm going to call the principal and have a conversation, or call the school nurse and have a conversation, because I don't think a school note is the answer today. I've written 3 school notes so far.
What I was going to say. School notes, you're not. It's not that school notes are never. Like, school notes serve a purpose to a point, and then right, and then we realize, wait, this is now enabling. We're not getting to we're just perpetuating this.
Yes. I might take it a little further than you might.
Okay.
In that I think missing school, even for medical issues, and missing school because you can't set your alarm clock, those absences aren't good for either child. So I'm not sure that a note of excuse is a good way to distinguish between those two things. And that gets into, what's a valid excuse and what isn't, right? And what's accommodation and what isn't. So it's a very complicated school notes. Right. I think school notes are really complicated, a complicated issue. But anyway, so when I'm standing there saying that to a parent, I think we've got to gradually work this child back into school. And I don't think a school excuse for me is an answer. I think I need to talk to the principal. And that oftentimes would get a very intense reaction from parents, understandably, because again, it's kind of counterintuitive in a way. And it's hard for pediatricians to to take that, like because it can end up in some hostility. It can end up in the parents stomping out. It can end up with them changing practices. And again, that's just that's not your typical pediatrician personality, to aggravate parents.
Yes.
So not only, so if we're feeling distress at the distress that this is causing the kid and the kiddo and the parents, then we get a glimpse of what kind of distress we're asking them to tolerate.
Yes. So I want to note a mantra that you wrote about, and then a quote from a wise colleague of yours. The mantra: "They are not faking. They are truly lost. They are experiencing what they say they are experiencing." And to truly embrace and internalize that when you're dealing with these patients and these situations. And then your wise colleague, Dan Spencer, says, "We believe we can help you, and we will hold hope for you until you can hold hope for yourself."
Yeah. Yeah.
Like that just encapsulates so much of what we've been talking about and what you've learned and write about and are giving to all of us. What would you say? So for parents listening right now who are like, we've been at this thing for a long time and our child might actually have an emotionally based illness. What's that next step for them?
So I think probably the pediatric provider, if they haven't tried that route before, or are or perhaps that they did try it and it didn't go so well, whatever. I think that pediatricians understand school anxiety, and pediatricians are pretty good at assessing when it can be handled from the pediatric office versus when we need to pull in a therapist. So I see that as the kind of the pediatrician as the hub in this case, in this situation, because we do have access then if they need a specialist, if they need a therapist, we can call the superintendent or the principal at school. I think the pediatrician is probably the best person
start
at the hub.
Right. And we'll tell you all information about where to get Maggie's book, but it not only is a great read, it will provide you with the words and the concepts and the knowledge, not only for yourself, but to help advocate for your child. And sometimes we have to educate our professionals, it's just this hopefully collaborative relationship. There's a lot of information out there that are always coming to doctors these days. People are self-diagnosing all the time. This is a way to really arm yourself with knowledge and come into the situation open with another possible explanation for what is probably confusing everybody.
Yes.
Okay, it's time, Maggie, for the parent footprint moment question. Here we go.
Okay.
Tell us about a time that you became aware of yourself as an individual, as a parent, or even an awareness of your own parents, and that new awareness had a positive impact on yourself, your kids, and or those you love.
Okay, so when I started in pediatrics, by the time I finished all my training and got board certified and all that kind of stuff, I was like in my late 20s. And I was, kind. I was compassionate. There was a lot I didn't know. And by about 3 or 4 years later, I had my first child. And the thing that struck me the most about that was, now I get the parenting thing. I mean, for a pediatrician to be board certified and licensed and everything, and not have completely gotten the parenting thing, but you don't realize it until you realize it. And so having a baby and then a second baby really drove home to me what it felt like to be the other grown up or the other two grown ups in the room and hearing what I'm saying to them and giving them the advice that I'm giving, and then understanding why their reactions were not always glowing.
Yeah.
I really got to see it. And to be perfectly honest, I would have some of these conversations about school anxiety, and I think they would stick in my mind because they were very vivid. You remember the tough ones. And I would leave that room, that exam room, thinking to myself, if that were one of my daughters and they were writhing on the floor, saying, I'm in too much pain, I can't go to school, could I do it?
Yeah.
Could I say, no, we're going, we plan this, we're going. And that kind of humility was really important. That kind of for me, maybe other people get it without being parents. I can certainly believe that can happen too. But for me, that sealed the deal in understanding parents' reactions, where they're coming from, and how much they just love their children and want the best for them.
Yeah. Oh, thank you for that. Such, again, humility, your openness and your humility. And I completely relate to that and had the same experience as a child psychologist, pre-children, and then having children. It changes the whole way you look at the kids, how you look at the parents, how you look at the interactions. And it's just, you can't just parent blame anymore because you realize this is way more sophisticated than that.
That's right. You're in the club, so you can't blame anymore.
Well, Maggie, tell everyone where they can find your previous book, this book, of course, and all of your writings.
Oh, thank you. Well, so so probably the easiest is Amazon.com, and just look under Maggie Kozel, MD, in Amazon.com, or the book's title, My Legs Are Crying. My previous book will also pop up there. That was more like a memoir and a healthcare reform. So it's available, and it's also on barnesandnobles.com.
I love the title. I mean, the title says it all once you understand this topic. My Legs Are Crying. Thank you, Dr. Maggie, for sharing your wisdom with us today.
Thank you for giving me the chance.
Thank you for listening, everyone. Please share this recording episode with anyone you think will benefit. So many people out there unknowingly suffering from emotionally based illness, and this raises not only awareness, but also how to talk about it, how to understand it, how to consider it, and how to help your child, your family go towards functioning once again. So important. Thank you for your 5-star reviews. Thank you for being a part of our community. Do your best to be that person you want your child to become, and ask yourself that guiding question I ask myself each day: what footprint do you want to leave? This has been a Peters and Rossi production. Parent Footprint with Dr. Dan is produced by Laura Rossi. Our engineer is Phil Rossi. Theme music is Strummerman, composed and performed by Pro Tunes. Artwork is by Garrett Ross. Follow us on Instagram and Facebook at Parent Footprint Podcast, and on Twitter at Dr. Dan Peters. For more information, go to exactlyrightmedia.com.